Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is Dr. Michael Dennis, the Chief Research Officer for Chestnut Health System's Lighthouse Institute and a Senior Research Psychologist. Mike, welcome.
Thank you. Glad to be here.
You know, when I had you on our maiden podcast, which was, by the way, about 46 podcasts ago, I asked you to send me your bio. And if you recall, you send me your CV, all 103. That's 103 pages of it. And for our listeners, that in itself should give you an idea of Mike's work, its volume, its breadth, not to mention its impact on the field. And of course, his stellar rep. I tell everyone that I can get just about anyone in the field on the pod. All it takes is an email or call from Mike, and doors magically open. I think your middle name is Open Sesame, Mike. Anyway, thanks so much for joining me. I really do appreciate your taking the time. So the theme of today's conversation is emerging adults with SUD and the need for mHealth solutions. So I think we should begin by defining what we mean by emerging adults. I believe that's people between their late teens and early 20s, yes?
Yep. In my case, we typically define it as 18 to 25. Biologically, adolescence is kind of 15 to 25 is the third major period of brain development. Lots of biological, sociological changes going on. And the reason we go 18 to 25 and separate them is that society as a whole, the legal system, the school systems, and everything sort of divide them there. It's not that there's something magical at 18, but legally they're able to do more things. We treat them as adults. There are new barriers and additional things going on. So we make that distinction developmentally as teens, typically 12 to 17, and young adults is 18 to 25.
Do you cap it at 25? Because my understanding is that is when and I may have this wrong, the prefrontal cortex has fully evolved?
Correct. That's the general reason why we put it there. There are certainly people who may stop at 24 or go on even to 29 or 30. It depends a little bit on what you're doing, but for the sake of today's conversation, let's think of it as 18 to 25.
Right. Perfect. So the next question that comes to mind is, why are you focused on emerging adulthood? Why is this so important to you and your work?
So the economic impact of drug use in the U.S. is about $272 billion annually, with the largest single share, disproportionate share being driven by emerging adults. Over 13 million emerging adults use drugs in 2023, including alcohol. 9.2 million of those meet substance use disorder criteria by self-report. SUD rates are the highest among emerging adults, about 28% of all people in that age group, versus for people 26 and older, it's about 17%. And for youth under the age of 18, it's only about 9%. Yet emerging adults with SUD are the least likely to access treatment, with only 1 in 30 getting care versus about 1 in 11 for adults and about 1 in 14 for adolescents.
Is there a common reason for that?
Well, there's several reasons. The issues are kind of intertwined. The healthcare system is very much driven by an insurance system, and adolescents typically are under their parents'. Young adults may be under their parents' insurance still as part of Obamacare, but many of them are not. They also tend to have moved out of the house and become semi-independent. They may not have as many connections to family or school systems or workplaces that are pushing them towards care. As a group, they have very high rates, but they're a small group. Most of the adult treatment system is focused on people 26 and older, with the vast majority being 40 and older. So you don't really have a practice that's geared towards finding them or getting them in. And their peers are still at very high rates of use. They haven't necessarily hit rock bottom and started clawing their way back out.
We use the term mHealth solutions. I'm assuming that a good amount of our listeners don't know what we mean by mHealth. So if you would give us a handy definition of what that means.
So the M is for mobile health. Really, you have Technically, smartphones were created in the 90s. It really isn't until the iPhone comes out in about 2007 that they gain mass popularity. When we talk about mHealth, there were already technological solutions, web-based things, computer-based health apps, and other things like that. But mHealth refers to things that are being provided directly via cell phone, particularly a smartphone. And the reason that's so important is it means help's in your pocket. People, if they forget their cell phone and going out the door, they tend to go back and get it. And forget it at work, you go back and get it. You don't really go without it. And so the more things you can deliver through a cell phone, then the more you're able to reduce access barriers.
Right. Right. So obviously we want to dig a little bit deeper into these mHealth solutions, but it does beg the question, if we're talking about mHealth solutions, we also need to talk about the traditional treatment methods. Clearly, they're not meeting the needs of emerging adults. Why is that the case? And how are mHealth solutions, generally speaking, we'll get a little bit more particular, filling the breach?
So only about 3% of emerging adults with SUD received any kind of SUD treatment in the past year. Even when they are engaged in formal service, emerging adults with, say, for instance, opioid use disorders are half as likely as older adults to be referred for medication-assisted treatment or medication for opioid use disorders. Emerging adults are also the age group least likely to be retained in any kind of SUD service, and this appears to be particularly because the services are not targeted at them. A young adult in a group or room full of people in their 40s to 60s kind of hugs the wall and doesn't feel like they fit. Whereas when you have a young adult focus program, they represent the majority of the people in the room. And that's just not true in very many places. There have been, and they are successful when you can do it, but there's very few of those types of places. What a lot of people try to do is refer them to a 12-step AA, NA, or other mutual aid program. There, again, the problem is that the average age of those groups is quite high. And if there aren't other emerging adults in that setting, they're not necessarily going to feel like it makes sense. And AA's and NA's 2.6 million, less than 2% are under the age of 21, and the majority are white. So as you go down in age, more and more people are mixed or a minority, whereas the higher up you go in age, the more likely you are to be white. And so they don't feel, not just from age, but also from race and several other things. They may just be in different places in their life, not talking about certain types of jobs or marriage or children. They may be in a different place.
You mentioned mHealth tools being, I suppose, effective. I don't know if it's the word that you use necessarily. You did use the phrase health in your pocket. So these tools are accessible. It's also a behavioral thing. Most emerging adults have an iPhone or an Android phone. They're comfortable using their phone. They use it to engage friends. They use it to buy things. They use it to check things. They use it to monitor their sports teams. And obviously it makes sense if they're doing all those things, the barrier to actually using it for their mental health, their behavioral health, their well-being, it makes a lot of sense.
Right.
So what are some of the things that they're using them for, again, in a broad brush? And maybe we could talk about some of the more efficacious tools. You could cite several of them by name. And also want to talk to you about the issue of evidence-based tools, because I know when these tools started emerging several years ago, there was a dearth of evidence-based tools. That may be less the case these days, but there may be also an issue when you have these tools when they're not supervised, people using them independently where there might be other problems that emerge. But I know that's a lot that I just said, so let's just back up. Let me ask you about how emerging adults specifically are using these tools.
Well, just to put a finer point on your original one, about 98% of emerging adults have already carry a smartphone, not just a mobile phone, but a smartphone. on which you can use these kinds of apps. And particularly of importance, the extension of high-speed cellular access and or broadband into rural communities. About 74% now have one or the other of those. So mHealth becomes a lot more feasible. Some mHealth apps sit on the phone and could work over any standalone or over Wi-Fi. Others interact with a server and require that high-speed access. But the quality of the phone, the operating system, and the cellular network, and the extent to which it covers where most human beings in the United States live has improved dramatically. There have been studies that have shown that some of the earliest intervention, Chess and Sark, are two brands that have multiple clinical trials behind them that have been shown to reduce substance use targeting that. Pretty much, there are also several that have gotten prescriptions. Now, FDA has approved some as adjuncts for care, where a physician can actually prescribe it and get an additional app and get some of their treatment through mHealth. But overall, mHealth is still kind of in its infancy. There's lots and lots of apps, but not a lot of them have been rigorously evaluated. And one of the problem is that when you look at mHealth apps, it's only about 30.4% are using them 1 month after they've downloaded it. So there's a lot of garbage, right? Or a lot of things that don't meet the need. It's worse for younger adults. They often use it about 20%, 21% only use mHealth once and then never go back to it. Use a particular app once and then don't really use it again. So the first thing is not only do you need the tools and the phone in their pocket and the cellular service and all this kind of stuff, but you also need an app that's appealing, meeting them where they're at. We do a lot of work with community boards of emerging adults to help us design and meet what they think is interesting and meet their preferences. And a lot of what they want is control and flexibility. So you may care more about music. I may care more about physical exercise. Somebody else may care more about games. All those things can work, but you may like one type of music app. I may like a different type of music app. It's the music that matters, not which app you're using. And so by having the ability to let us each use what we're used to and where we have our playlists tends to work better than me trying to force you to use just one way. So when you talk about evidence-based, it's less about this app and more about the type of app and how it has been implemented and how it's used. Really, in terms of the specific apps, in a lot of cases, we haven't found some unique thing that mattered as much as the fact that you're using, somebody vetted these apps, put them together. They're not full of ads. They're not full of scams. They work on different types of platforms and they've checked them out for you and they're a good thing and people like them in this age group. That's going to be pretty much whatever you gravitate towards. If they're pulling you away from using or craving, cravings on average only last about 2.5 to 5 minutes. If I can get you distracted with a couple songs, a couple games, the craving will be gone and I can get you past it. In fact, we've shown in some pilot work that we could cut the likelihood of you using again the next 24 hours in half if I could get you 2 clicks into the mHealth app. So utilization is sort of king. And there is one app, there are 2 apps that actually on opposite ends of the spectrum that tend to stand out above all the rest. Number one is a music app. Doesn't matter so much which one you use, but when you play your music, there's actually brain scans that show when you're listening to your music, if your brain was agitated, it calms down.
So Mike, let me just say, so in other words, I'm sorry to interrupt, but so in other words, this is not necessarily an mHealth app. It's a music app that actually functions sort of as an mHealth app to the extent that for those few minutes where you might have a craving, it's sort of
they're
redirection.
off-the-shelf apps, Pandora, Spotify, SoundCloud, 6 or 7 different music things. I don't mean to endorse any of them. They don't matter which one you use. Matters is that you have a playlist of the things that tend to calm you down and make you feel good. And that when you're agitated, if you go to your music app, whatever it is on your phone, you don't need a fancy mHealth app, but like when you are anxious or angry, you can go into a room and have a quiet space where you can calm down. You can put on your headphones and listen to your music, and we can actually see into the brain with brain waves and see that when you're upset, your brain waves are physically agitated. The lines are going up and down. And when you listen to your music, your lines, your brain waves calm down. Now, my music, and you may not do that to you, right? Like rock, I like country. Listening to country may agitate you more. I don't know what it is that drives you. But the point is, the reason you like certain music is because it syncs with your brain, and your brain feels more calm and happy when you're listening to your music. So one of the things we teach in our mHealth app is how to use music. For other people, it's physical exercise. For other people, it's games. But the one that tends to cut across is using your music, even if it's a different app or a different genre of music. But the one that matches you tends to make a bigger than average impact. The second one that makes an impact, and it's very common, it's one of the most common apps that emerging adults use. The second one is a much rarer app to use, but it turns out to be really critical, and that is that they have a support team. Now, if you think of 12-step, that could be a sponsor. You think of treatment, it could be a counselor. If you think of somebody self-managing their recovery, it could just be a family member, a grandparent, a parent, a brother, a sister. But the point is that they have identified somebody who really can help them out in a crisis. Whether that crisis is due to craving, an environmental situation, like they're at a party where everybody's using and they need to get out of it, whatever, when that happens, although rare, it's critical that that turns out to be another thing that tends to drive an outsized effect above just the average of all apps. So those two extremes, the really common music, which seems to resonate with the human condition. Some kind of music resonates with most human beings. And at the other end, a rare thing, which is identifying a person who you can call on in a crisis, whether it's craving or situational.
You know, you just completely, in my mind, redefined mHealth apps. Because again, when I hear mHealth, I think of very specific apps which guide you through mindfulness, exercise, an app like Calm, etc. But what you're talking about makes such perfect sense, particularly emerging adults grappling with SUD.
We don't care, like with physical exercises, there's a subgroup of people for whom they use exercise to clean out their brain and health and get back in shape and get their endorphins flowing. And that works for a subset of people. But we don't care which app they use. We say a solution is to do physical exercise. Right. Here are the most common ones. If you use Fitbit and I use Google Health, or somebody else uses Apple Health and you're already into it and got it, or it fits your phone or your lifestyle, it's great, but it's like a diet. Diets are another thing. It only matters if you do it. And if you find it amenable to your lifestyle, if you can't incorporate it, if there's no one diet that's radically better than the other. NIH even put out a diet called AIM, which combines the most common components. You could use the AIM diet, but sometimes it's the app that helps you with reminders. It helps you count calories. It helps you track what you're doing. Right. It gives you recipes to help you cook. Different apps do different things. And if you hate cooking, the recipes aren't going to matter, right? On the other hand, you can, for nutrition or other kinds of things like antioxidants or other kinds of things to help you detox. Maybe you're real into nutrition and doing that helps you with your motivation to get in recovery and clean up your body. So we don't try to prescribe apps as much as we train people on how to use different sets of apps. And in each of those sets, we identify the most common ones that are out there that are well used, well received. And then we allow them with the carousel to, within each bucket, to identify the ones they've used the most and even rate them. But there's also just a usage where they can scroll through the apps, but when they go to a music app, the first thing that's going to come up is the last three you've used. And if they're all one type, it's going to be the one type that you use, but you can still see the others. But we learn over time what you will use and or allow you to add things or pick something. Now, if you want to add an app like a new game, we're going to check out, does it have fees? Does it have ads? Does it have, is it a hoax that's trying to get into your business and, steal your phone or your private information? We're going to block anything like that. We also tend not to promote any apps that promote doom scrolling, which it's a little bit less problematic with emerging adults than teens, but it's still there. We don't want to promote any app that's going to be related to alcohol or drug use, violence or pornography. They have enough problems without us making it worse. So we tend to be pretty open to any app somebody wants, as long as it's not a scam or creating a lot of garbage, or it's one of those categories.
Yeah, no, this is fascinating because you're almost literally replacing a bad habit with a good habit, or moving somebody from a momentary craving to something they're predisposed already to doing. And it seems to me that, even the idea of breaking a habit psychologically can be an impediment. But if it's really just a matter of gravitating towards something you enjoy doing anyway, I'm going to enjoy listening to music, whether I'm in a good mood or a bad mood. It's just something I do reflexively and I enjoy. And if all of a sudden, that's a positive thing, it's almost like the proverbial hot fudge sundae diet. It's a really terrific solution, right?
Yeah. The other thing that we point out is in classic psychological theory on behavior modification, it's so hard to create a habit. It's pretty hard to break a habit. The easiest way to break a habit is to reinforce a competing habit. So by picking this range of things, which they probably have heard about or used some of these things, but by pointing them at the things that they and or people like them have found useful, they're still sociologically very influenced by their peers. They see ratings. They see that these are good things. They can look them up online. They're readily available to them on an app or an Android or other types of phones. They will quickly realize that it kind of appeals to them, and there's some options, so they have a sense of control. It learns by their preferences to show them what they want. They can manipulate. There's nobody manipulating them behind the scenes. They're in control. And if they want to go try something else, they can. Even when we try to increase utilization with something like contingency management, we want to increase the frequency of use, the consistency of use, that they're using it every week. It's not just something they use once and done. We want to see them use it multiple times, at least once a week or a couple times a week. And we'd like to see breadth, because we're giving them so many apps. The first one they open is likely to just be the one they know about, right? But we want them to shop around in the different apps and find the one that resonates to them. And that really is part of why we're reinforcing the breadth of what they're doing.
So to some extent, this is very much self-directed. To what extent do you need this to be supervised so you bring these things to their attention? They may otherwise default to what they know, what they're comfortable using. So how do you promote that, which obviously goes to the retention challenge?
Well, we do it. We try to train them on everything. We've tried to use community boards of other emerging adults to make the app more appealing. We try to train them on how to use and expose them to what the different things do and why they might be interested. We will do typically 1 week check-ins to see if there's any problems where something isn't doing what they think, and we try to go reiterate the training. We don't assume that they're going to get it once and done. We're going to go back in with them and make sure that they're using it and the app's doing what they want, and show them if they want to tailor it, how to do it. There's some setup screens, like where I was telling you about who's their sponsor or supporter that they can turn to in a crisis. We'll make sure that they identify that so that the app can suggest that person. So we'll try to identify those things that they use. And we'll put in some things like their motivation for change, pictures, words, or stories that help remind them why they want to change. This all comes from something called relapse prevention therapy. It's probably one of the more widely used techniques within substance abuse treatment, but it's often done in a group or an individual session in treatment. But then when people go out in the community, they may or may not use it. But now we're in their pocket. And we've taken, like in the old days, we used to make cards that said, what are my risk factors? Where am I going to be most likely to relapse? Who's going to get me out of it? What can I do? What are my solutions? Who do I call? What do I ask for? Those cards, which used to go in your wallet, now go into your smartphone. We can connect you to 800 numbered lines, not just 988, but there are things like Boys Town has a Your Life, Your Voice app that allows you to text or go to a bulletin board or call somebody. There's other 800 numbers for suicide prevention, other things. We can put all that on the phone. If they have a counselor, if they do have a counselor, we'll put that counselor's name and number on the phone so that they don't have to go looking for a piece of paper that they probably didn't hold on to. We're making sure that everything's on the phone at their fingertips, which is meeting them where they're at. That's how young adults and emerging adults organize their life, is on their phone. So we're just fitting into their space.
Right, for sure. We touched on rural communities, and we know there is a high incidence of SUD among emerging adults in rural communities. And we know that a large part of the problem is access to resources, which is to say lack of access. Obviously, now you have these tools, these phones are in your pocket. They're fairly ubiquitous, but they also require broadband access. How ubiquitous broadband access these days in those communities?
It's up pretty dramatically. About 74% of rural communities now have broadband of some kind. Now that is a big word, so that could be DSL, which is better than dial-up, but not much, to cable or typically fiber would be the best. Lots of people will have things like a Starlink or a HughesNet satellite that may pull things in. They may not be the best for Zooming. Right now I'm Zooming with you over a Starlink link, which does pretty decent. Some of those are less good for video streaming, but you can still participate in virtual meetings. You can do virtual treatment. You can do e-health solutions with providers. You can connect to other groups of emerging adults across the country. So it really opens them up as opposed to, and to back up and make your point, rural communities, the majority of the United States are rural zip codes. Geography-wise, the majority of the population are in urban zip codes, but the majority of the physical space are in rural communities or even frontier communities, which are less dense than rural. Rural now has gotten to a point of having pretty decent high-speed access, enough to make this work, particularly if you have Wi-Fi at home or Wi-Fi in a library or other access points. What they don't have necessarily is behavioral health services. So the access issues are even worse for young adults in rural communities than in urban communities or suburban communities or even small metro communities. So the rural is really the hardest hit. Emerging adults are the hardest hit geographically. The rural are the hardest for access. They don't necessarily have a higher rate of substance use disorder, but there's less available to help them. As a consequence, stimulant-related overdose, for instance, is about 1.4 times more likely for emerging adults in rural versus urban areas. So some of the same epidemics, but because they don't have free drugs to reduce an overdose, like the naloxone, necessarily have treatment or as much prevention, they have higher rates of overdose.
You know, I tell you, I've done quite a bit of work in the mHealth space. And this is really an enlightening conversation for me, because what you're doing is really recontextualizing a lot of these apps that people, particularly emerging adults, already use. But now you're putting it in the context of mHealth, how they can use them to get through these bad cravings and move them to more productive behaviors. Again, doing what they're already predisposed to doing. It's just an amazing, smart solution, and I can see it being particularly effective.
So the other issue with mHealth is that in the context of emerging adults where there's such limited access to treatment and even e-health kind of telehealth kind of situations, mHealth is something they can self-manage. And so a self-managed mHealth is really something that doesn't wait. It kind of bridges the gap from prevention and early interventions to co-occurring during treatment, following up after treatment. And if you look at the management of other chronic conditions, diabetes, hypertension, a lot of that is self-management. You have to learn to monitor your blood sugar, understand what it means, understand when you're having an episode and you need more help, when you need to call in a doctor, how you can manage with exercise or diet the things that are going on in your life, how you can calm yourself down. Pretty much all chronic diseases have this need for teaching patients how to do better self-management. And this is using in the absence of adequate treatment resources, this is trying to meet them not only where they're at, but also in terms of this self-management tool.
Mike, this is really an excellent conversation. I really do appreciate your time today.
Happy to help.
Today, I spoke with Dr. Michael Dennis, the Chief Research Officer for Chestnut Health Systems, Lighthouse Institute. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.